Hi, good morning. Chris Hall, Wake Forest School of Medicine, Infectious Diseases, with an update on COVID and other sundry viruses that people have been hearing about and over the fall here. So we're coming up on the holidays. We're almost 2 weeks out now. I guess we are 2 weeks out from Thanksgiving. And so we're getting ready for what would normally be the height of our cold and flu season. So before I get into what's going on now, let's do a little bit of a review as to what things were like for us before COVID. Before COVID, when late December came around, is when we would start seeing our cases of influenza, particularly in school kids. And then as we got into January and February, our flu cases would usually spike, and our peak would usually come in February and then tail off in March. And by April, it was over. There were a lot of other respiratory viruses that tagged along with that. Most of those that would include things that usually cause colds and or illness with coughing and such. And so if you remember, back before COVID, we just kind of endured this during January. It was cold and flu season. And so you just kind of expected it. Since COVID has come along, that usual trend of peaking up in December and into January and February has completely changed. And so this year, what we have seen is RSV, which was a virus that for most of us caused colds with a lot of coughing. It's annoying. It's the one where you wake up in the morning and cough for a couple hours and then cough intermittently through the day, and it may be associated with a little bit of wheezing and bronchospasm, and it lasts for about 3 weeks. But for little babies who have tiny little airways in their lungs, when those airways get involved and when they narrow, it makes it hard for them to breathe, and then they can get pneumonia. And so we've had a devil of a time with RSV across the whole U.S. actually, but including here in the triad, and it's caused a lot of hospitalizations, particularly for children under the age of 12 to 18 months. And Brenner's Children's Hospital here in the triad has been one busy hospital, and with kids with RSV. The other virus that we've been dealing with over the fall has been influenza, the flu. For the most part, it's H1N1 influenza, and it has started up late September and into October, particularly in our kids. And it was really going around the schools. There was one time where West Forsyth High School in town had over 400 people out with the flu on one particular day. And it roared through the schools. Schools aren't masking now. And so that virus took advantage of that. And when we got into the holiday of Thanksgiving, so we've kind of had these two viruses, RSV and flu, giving us a hard time this fall. And where's COVID been during all this time? Kind of asleep, hiding out, hanging out in the bunker, I guess. Our COVID cases have been real low over the fall. And it's interesting and how the flu in particular, but other viruses as well, and COVID tend to predominate on one of those tippy scales that you can see, or the teeter-totter. When one is up, the others are down, and then vice versa. And we've seen that now over the last 2 years. There is some speculation as to why that is, but we don't really know exactly why that happens. Now, over the last 2 to 3 weeks, we're starting to see some changes. And these changes are, one, RSV numbers have declined considerably in kids, particularly here in North Carolina and the Triad. There are some other regions in the U.S. where it's still circulating pretty heavily, but around here it's declined. So we're well past peak for RSV now. The other thing is that flu or influenza has been less of a kid problem in the schools problem and more of an adult problem. And this usually is what happens with flu, because after it's been with the kids for a while, they bring it home and then the adults get it. And then lastly, it tends to be the elderly who get it because they're exposed a little bit further down the line. So we're starting to see our numbers of influenza be more of an adult problem than a kid problem. The other thing is that with influenza, and knock on wood, if I could find some, cross my fingers, throw salt over my shoulder and all that, but over the last 2 weeks, it appears that our influenza numbers in North Carolina, as well as here in the Triad, have started to decline. And they're declining slowly, but they are declining. We'll have to see. Our numbers come out for this afternoon, so I don't know them yet for today, but this afternoon I will. We'll have to see if that trend continues for it to decline. But it's not all rosy. Our COVID numbers are starting to go up. Starting 3 weeks ago, our wastewater numbers started to go up, including here in the Triad for COVID. And you remember we monitor our sewage for COVID particles, and those numbers have started to come up. It had actually started to come up before Thanksgiving. And then now, after the Thanksgiving holiday, we're starting to see more cases in people, and we're starting to see more emergency department visits for COVID, which we'll talk about in a minute. That's not where you should be going for your COVID. And then we're starting to, in some areas in the country, we're starting to actually see some more hospitalizations for COVID. Here in the Triad, the numbers have come up a tad for COVID in our hospital, but it's still not real high. Now, let's put all this in perspective. RSV is down, almost out of the picture, kind of. COVID, influenza still up high, but looks like we've come past peak and starting to come down. COVID down here, starting to come up. And we're still seeing probably about 15 times as many positive tests for flu as we are for COVID in the area. So the flu is still the one that right now. But I think by Christmas, if these trends continue, which my prediction is they will, we'll be entering more of a COVID time for circulating viruses and less of a flu time. Now, this is exactly what happened last year, actually. We did have flu in the fall, particularly in universities and some in schools. And then it went down by mid-December. But remember that last year, Omicron was the one that came around. That was at the end of December. And then we had a horrible, horrible peak, huge numbers of cases. In fact, we estimated 70% of people in the United States got COVID last January and early February. So that was a lot of cases. Our hospitals were packed, and we had a lot of healthcare workers out with COVID themselves, couldn't come to work. It was hard on our hospitals, and I really don't want to go through that again. So my prediction is I don't think it's going to be quite like it was last year for a lot of reasons. One, our population has more immunity in general, and we'll talk about what immunity, past infection and immunity means. More people have gotten booster vaccines over time, which has increased immunity. The subvariant strains of Omicron that are going around now don't appear to be any more severe than they were last spring, which is good news. So I think we're going to have less severe disease with this coming season. I think we'll have fewer hospitalizations due to it, and I think we will have fewer deaths. So that's my prediction for this. I'm not alone. There are other infectious disease experts who've been saying this as well. And so, but what will it mean? It'll just mean it's going to be a pretty big cold and flu season, COVID colds. And so for most people now who've been previously vaccinated or have previously had COVID, getting COVID is you know, it's an illness like a cold. Starts out with a bit of a sore throat, stuffy nose, progresses into a cough, runs its course in a few days, just like a lot of the other cold viruses. The fever is not as significant for people who've previously had COVID or who have been vaccinated and boosted. But what it does do is it makes you sick. No one wants to be sick, particularly around the holidays. It's inconvenient and it's annoyance. It's hard for families with childcare, continuing to work, do all your holiday preps. It's hard if you want to travel, because you really shouldn't be traveling if you have COVID. It is still, if you have COVID, you still need to isolate for 5 days at least, and then come back to work or school or wherever. In the next 5 days after that, you still have to wear a mask. So it impacts your life for 10 total days. And that isolation is still strongly recommended, and I agree, that helps prevent spread of COVID. Not only that, but it's also being a good citizen and doing what you're supposed to do and not make other people sick. And it's also polite. Going to the holiday Christmas party when you're sick with a snotty nose and a cough is rude, and you shouldn't be doing that. I think that's going to be the big problem. So with that, COVID colds and COVID illness, there's still three things to think about and three impacts that is going to have on our society. Impact number one, absenteeism. So if you have COVID, you don't go to work, you don't go to school. If you're a student and you have exams, that's a problem. You got to reschedule the exams. It's harder to study for them. Absenteeism in the workplace. You don't have as many people coming to work. For us in the hospitals, we always have problems with absenteeism in January and February because cold and flu season, and it always stresses us out a little bit. Last year, it really stressed us out. Absenteeism in a fire department. Absenteeism in a police department means you have less public safety people coming to work. So on and so forth. You can look at your own work situations or your home situations and see how absenteeism might affect that. That's the second thing is immunocompromised people. Now, I said COVID mostly, for most of us, if you get COVID, you're going to have a bad cold. But for people who are immunocompromised, it can be a really big deal and land you in the hospital, and it can cause bad pneumonia, it can cause bad problems with other organ systems, and you could die. And so for immunocompromised people, a COVID wave is kind of a scary thing for them. The thing about that is that, when you're immunocompromised, you don't respond as well to vaccines or previous infection. So that means even if you get vaccinated and boosted all the time, you may not have a good immune response from that. And so that you could still get severe infection. So for immunocompromised people, it's a big thing. Also for people who are really elderly or who have a lot of underlying health problems, getting COVID is still a thing. You may end up in the hospital. You could even end up in the ICU with it. So for those groups of people, This is going to be something that they're going to have to work around in January and February. And then the third aspect for COVID is that even from the milder cases, there are some times when you can get long COVID. And that means long-term fatigue and tiredness and brain fog and other things. So even though for most of us it's going to be COVID colds, for some groups of people, this is something they're going to have to deal with. And I'll talk about some things that can be done in a minute. So how do you tell the differences? How do you tell the differences between flu, COVID, and some other junky respiratory virus, okay? So COVID will usually cause a sore throat and runny nose for the first day or two, and then it progresses to a cough. Flu usually starts with a sore throat and runny nose, but for a shorter period of time, and then progresses to a cough. So they sound the same. One big difference between the two is that COVID, the fever kind of comes up gradually over a day or two, and for a lot of people who get COVID now, they don't even have a fever. But flu hits you like a brick within a period of an hour or two, usually. When I'm seeing people in the emergency department and they say, "Doc, I think I got the flu," and I say, "Well, what time did you get sick?" And they said, "Well, I was watching, my favorite reality TV program, and it was around 4:30. And then all of a sudden I felt horrible. Headache, bad body aches, fever with my sore throat." And that's very characteristic of the flu, where COVID comes on a little bit more gradually. Flu usually hits its peak on day 2 or 3, and then it goes away. COVID can last longer, and actually for some people, the ones who progress to more serious infection, day 7 to 8 is the worst part about it. COVID can affect your sense of taste and smell. Flu doesn't do that. So those are the big differences between the two. Do you really need to sort it out and figure out what they are? Yeah, it's helpful for a few reasons. One is that your period out of work or school is different depending whether you have flu or COVID. Flu, 24 hours after your fever goes away, you can go back to work or school because you're really not contagious anymore. COVID, you still have to be out for a full 5 days. And then when you come back, you're supposed to wear your mask for another 5 days. So your period of staying home is a little different between the two. The other thing is that we have medicine for flu. Tamiflu is the one most people know. And that will help if treated early. It'll help push down the symptoms, get you better a little faster, and reduce transmission, particularly in your old household. So you can get Tamiflu if you have the flu. And then we have treatment for COVID, and that's different than the flu treatment. The big one is Paxlovid. Paxlovid is usually we reserve that for people who are at higher risk for getting more severe COVID, so people with underlying health problems, people over the age of 50 to 60, so on, or people who are immunocompromised. We give them Paxlovid. So it is important to differentiate them. Now, most of the cruddy other respiratory viruses that cause colds don't give you a fever. They don't cause all the headache. They don't cause all the body aches. It's just mostly junked up here, and with or without a cough. And so you can kind of discriminate a little bit. So what happens if you get your respiratory infection here in the next few months? How should you do it? 1, test yourself for COVID. That's not hard to do because you can get the test at all the pharmacies, and you can do it at home. There are other testing sites still available, urgent cares, for instance, and other healthcare places. Some primary care offices will have the test still. So you can test yourself for COVID. If that test is negative, then you need to decide, could it be flu? Right now, because we still have a lot of flu circulating, if your COVID test is negative and you have a fever and body aches, assume it's the flu. And you can call your primary care doctor, that's probably the best way, and ask them if it's appropriate for you to get a prescription for Tamiflu. There's just so much flu circulating right now that if you got a fever, a headache, and a respiratory thing, that's probably what it is if your COVID test is negative. If your COVID test is positive, then begin your 5-day isolation. And if you have underlying health problems, or you're over the age of 55 to 60 or so, or you're immunocompromised, call your doctor and get a prescription for Paxlovid. And so you can still stay home as long as you're not that ill. You really shouldn't be going to the emergency department. The emergency departments are busy. Unless you have a pension and just love sitting and waiting for 4 to 8 hours to be seen, I probably wouldn't do that. But if you're short of breath, or you're confused, or it's affecting you so badly that you need help to get around and to do things, then you should go to the emergency department. But that's an emergency. So otherwise, you can go to urgent cares. We have a new urgent care for Atrium House, Wake Forest Baptist in Kernersville. Check it out. It's pretty cool. But it's best to stay out of the ED. So what about for the immunocompromised people? Because I always have quite a few of those who watch. So there are some things still. We still have some tools in the toolbox. Let's look in the toolbox and see what we got. First of all, we still have masks. And you can wear an N95 mask, and you're not going to get COVID. You're not going to get flu. You're not going to get RSV or one of the other junky respiratory viruses, because it inhibits all of them from entering your airways. And you're still going to be washing your hands frequently in case you pick up some virus from the environment. And you can still do that. I'd particularly do that when you're in situations around other people, particularly traveling or crowded places, going to see the Nutcracker, so on and so forth. You can wear a mask. Those of you, even if you're not immunocompromised and you just don't want to get sick, wear a mask. And you won't. And it's okay. There's no rule or law against it. And you wearing a mask is going to protect you even if other people aren't wearing a mask. So you could do that. The other thing is if you're immunocompromised, you might want to change your activities a little bit through January and February and after the holidays. And lay low, chill out a little bit, spend more time at home, avoid big crowds, going to places like that. Unfortunately, treatment now for immunocompromised people is just Paxlovid. All those monoclonal antibodies that you remember, they don't work anymore because their primary variants, the subvariants that are going around now, are BQ1 and BQ1.1, and our antibodies that worked up until August and September are no longer active. The other antibody treatment called Evusheld, which you could get every 3 to 6 months or so to protect you and keep you from getting COVID, that one likely doesn't work anymore either. So we're really left with Paxlovid for immunocompromised people. Changes in behavior and wearing a mask. A few other things coming around and to talk about. Whether you're immunocompromised or whether you are otherwise healthy, you still should get vaccinated for both COVID and the flu. and these vaccines are readily available. The flu vaccine this year seems to be a pretty good match, and it'll keep you out of trouble with the flu. It may not totally prevent it, but it'll certainly reduce the severity, and for about 60 to 70% of people, it'll totally prevent it. And the flu vaccine is out there. Unfortunately, we haven't had as many people getting the flu vaccine this year. I think there's just a little bit of fatigue about going out and getting shots. Also, people forgot about flu for some reason, but you can get your flu vaccine. The COVID vaccine that's available now is what we call the bivalent vaccine, which means that it is enhanced for Omicron, and that includes the subvariants. Now, BQ1 and BQ1.1 are a little bit more evasive for the bivalent vaccine, but it still does a pretty good job. And it'll certainly help protect you against more severe infection. Limit the amount of symptoms, limit the time you have it if you do get it. So I would recommend that you get it. I have gotten it. I've got my flu vaccine, and I got my the bivalent COVID fall booster. I got them at the same time, one in each arm, and it was fine. More convenient. Don't have to go back to get the other one. So get vaccinated, and it really is going to help you get through this January and February. Some other diseases going around, and then we'll open it up for questions. We talked a little bit about monkeypox. Monkeypox is kind of the health emergency's over for that. And you know, it reflects really a good job by public health and communication, and the people who were at risk of getting monkeypox for the large amount went out and got vaccinated or changed their behaviors, because a lot of it was being transmitted through close intimacy and sexual contact. So we're not really seeing many cases of monkeypox now. The other one we had talked a little bit about was the outbreak of Ebola in Uganda. You may not know it, but the hospitals here in North Carolina, the big ones, the big hospitals, including here at Atrium Health, Wake Forest Baptist, have been going over their Ebola plans and how to take care of Ebola patients and how to do it safely. So just in case a case should come to the United States from Uganda, we would be able to handle it. I think there's some sunny days ahead for the Ebola in Uganda. It seems like the cases aren't going up explosively. The cases in the big cities, almost all of them are imported from the countryside, from the districts outside of the capital, rather than being transmitted in the capital. I think Uganda is going to be able to get a hold of this and get it under control. We are starting to put into a trial on a vaccine for Ebola Sudan, so that trial will be starting soon. The Ebola Zaire vaccine works pretty well, so we anticipate Ebola Sudan will work well too. And there's a couple medicines out there. One of them, remdesivir, which, if you remember, is also a COVID medicine for hospitalized patients, but also works for Ebola. So that's what's happening with that. So I have a few questions here off of Facebook that we'll go through, and then we'll open it up to everyone. The first one is do you think that Novavax is likely to receive approval soon for use as a booster dose beyond just the first booster? Novavax, if you remember, is a protein-based vaccine that has an adjuvant in it. It's made the same way we make HPV vaccine and hepatitis B vaccine and these other vaccines that we've been using for a long time. It does not have messenger RNA in it. And it works pretty well. It works about as well as the messenger RNA vaccines. It is approved as a booster down through adolescence, I think. Yes, I think you can use it as a second booster as well, but that would be probably 4 months or so after the first booster. So yes, I think we will see that. The new COVID variants are causing COVID to rise in Australia, where it's almost summer, but not here yet. Is that because other circulating viruses, such as colds and flu, are suppressing COVID here? Well, we talked about that a little bit. I'm not exactly sure why. For a lot of these respiratory viruses, the southern hemisphere, so Australia, tends to be on the flip-flop from what we are. But you remember last summer? We have, for the past 2 years actually, we've had a summer wave of COVID. It's not as bad as the January and February, but it's kind of a July and August one. Remember Delta? That was a bad wave in the summertime. This past summer we had a wave of BA5. So I think that's what's happening in Australia now. They're probably entering a summer wave. Any up-to-date studies on how long strength of vaccines and boosters will protect? Personally, fully boosted and flu vaccinated, age in the 90s and comorbidities. So far, it looks like our vaccines, both the bivalent and the one we were giving before the bivalent, are still doing a good job keeping people out of serious trouble. So if you get COVID, you might get kind of sick. You might get hospitalized, but it's much less likely you'll end up in an ICU or die. And so they're hanging in there from that standpoint. As time goes on, the vaccines tend to protect less from just milder symptomatic disease, COVID colds. That tends to wane over a few months, that protection. But the protection against serious disease looks like it's persisting. Boosters do top you off immunologically, and the question is what are we going to be doing as we go into the future about boosting? Will we be recommending a booster again this spring? Some of it will depend on what happens in January and February, and some of it will depend on whether there's any new crazy subvariants out there waiting to come down the pike. We haven't, but right now I would say probably not. But we may be getting a booster every fall, maybe. And that booster may be modified some to reflect what the subvariants are that are circulating. I'll tell you, it's a little bit controversial. We have debates in the infectious disease world about that. So we'll have to see if we're going to have another fall booster next year. So if one is fully vaccinated and boosted the first go around for COVID, how do we know if we need more boosters? All right, so here's how you know if you need that booster right now. If you have not had a COVID booster since the first week of January, or I'm going to start over, grab the wrong month. If you have not had a COVID booster since the first week of September, then you should go out now and get a fall booster, because that's when we started giving the bivalent Omicron-specific booster. So if you have not had a booster, whether you're old, if you had 3 boosters before that, 2 boosters before that, no boosters before that, if you haven't had a booster since the first week of September, go get your fall booster, just like we do our flu shot every year. Last question. My daughter has had COVID 4 times. What do you suggest for her? She is almost 50. Well, I don't know your daughter's health situation, so 4 times is a bit on the extreme. Well, we have, reinfections have been happening in people. Having COVID twice is not uncommon. But 4 times is. It may be something you might want to talk to your physician about. The other thing is if you haven't been vaccinated, get vaccinated. If you haven't been boosted, get boosted. And then see what your doctor has to say. The thing is there are, every time with viruses, sometimes certain people, for some reason, don't mount an immune response against a specific thing, and they're more susceptible to it. It's pretty unusual. And that's the case even with COVID. There are still a few people out there who've not had COVID yet, even though they're out and about and doing things. These people probably have something about their receptors or their cells in their body or the immune response that's helping to protect them. But the other end of the spectrum is there too. There are some people who are just highly susceptible to it. It's pretty uncommon, but that happens. We see that with other germs in medicine as well. So any questions from the group here? Yeah.
You said that COVID cases are slowly beginning to increase right now. Do you know what's really causing that? Is that because colder temps are coming, people are gathering inside, because of the number of booster shots or vaccines or a combination? Just what's really driving this up?
Yeah, so the question is why are our COVID cases starting to increase right now? It's likely a few things, as you mentioned. One is that during when temperatures get colder and it's dark more, people spend more time inside and they transmit viruses in households. That's one. Two is that COVID does persist longer, both in the air and on the surface, and when it's cooler and perhaps even more importantly, less humid. So when your furnaces are going at home, your humidity drops considerably. It gets dry, and so that helps. It bounce up and towards the end of December, January, and February. Same thing's usually true with the flu. Some crazy reason this year it was more of a fall thing. But a lot of viruses are more persistent in January and February because of the temperature. But a lot of it's get-togethers and people spend more time around other people, close proximity. So it'll happen again this year.
Can you talk a little bit about a report that hospitals are near or at capacity for COVID, RSV, and flu combination?
Yeah, so, and by the way, people have been using this term, tridemic, because of all three viruses. I don't like that term very much. I think it's just, people should just think about it as kind of a bad cold and flu season, and it includes COVID. But yeah, so, people particularly who are at the extremes of age, and that's very, very young people and older people and people with underlying health problems, if they get flu, they sometimes land in the hospital. And that's been true even before COVID. And then RSV, the people who get hospitalized with RSV are either people who are heavily immunocompromised or babies. And so over the fall, the hospitals that have really been, struggled some, they're hanging in there, but they've been very busy, and it's been a tough time for them, are the children's hospitals, because the RSV in particular has made them very busy with respiratory infections. COVID, over the fall, probably about half the people who test positive with COVID in the hospital are in the hospital for some other reason. We've actually had a few people who have been hospitalized because of the flu, and then we test them and they have COVID also. But it's the flu that landed them there. So yeah, it's been kind of a busy fall, but particularly for the children's hospitals. I think for the more of the adult wards and the specialty wards, particularly those that take care of older people, the geriatric wards and the wards for immunocompromised people and the cancer hospitals and stuff, their time is yet to come. It'll be January and February. Yeah?
You mentioned earlier that you believe this season will be less severe for COVID cases, less severe illnesses as well. Can you explain why you think that, especially with now people are wearing less masks than last year?
So I do think that the COVID season this year is going to be less severe. And the main reason is that our population as a whole has at least some degree of immunity for the most part. Either you've been vaccinated, boosted, or you've had COVID in the past, which gives you antibodies, and you've been exposed to it. So the more the population gets exposed, the more immune it gets. And that, remember about 6 to 12 months ago, we were always talking about how COVID was going to end up being endemic, going into endemicity, rather than a pandemic or an epidemic, it'll just be endemic. That's part of that process. That's kind of what's happening. So the other reason is the Omicron, and the Omicron subvariants seem to be less virulent. Virulent's a word that we use that means mean. So it doesn't quite cause as much as severe of an infection as the pre-Omicron. Delta was the worst. Delta was a mean virus, but it's not as severe as that one. So I think that's the two reasons. I mean, we'll still have cases, we'll still have people in the hospital. As I mentioned, for immunocompromised people, it's still, getting COVID will be a serious thing. But otherwise, I don't think our hospitalization cases or deaths will be as high. Yeah?
You mentioned 2 new subvariants as well. For those who have not had a recent booster shot, how concerned should people be about the new subvariants from your perspective, and how much will the new booster shot really help with that?
Yeah. So the new subvariants BQ1 and BQ1.1, which, by the way, now the two of those together, probably here in the triad, is about 70% of what's circulating. So the Omicron bivalent fall booster is better for those than the first COVID vaccine that we were giving. It's clear the antibody levels are higher; they're more specific. But it's not, that vaccine is not quite as potent as it was for BA.5. But it's still pretty good. So would I be concerned about those variants after getting boosted with this vaccine? I'm not. I got the fall booster, the Omicron bivalent, because it's gonna still keep you out of having a nasty infection. If you get it, it's going to be more of an annoyance. Yeah, I recommend people to go out and get it. Yes?
You know, there are certain medicines going in short supply right now. These like Tamiflu, for
Yeah.
instance, and all that.
Tamiflu is a little hard to get right now. Tylenol, even for kids, children's Tylenol, I guess, has been on the short supply.
How much do you think that's really impacting the increase in like flu cases?
Oh, I don't think that getting the medicine has had much impact, not being hard to get the medicine. You know, if you give Tamiflu, you can reduce the odds of transmitting it to another person. And then sometimes we'll use Tamiflu to protect somebody who's very vulnerable to the flu. So if you know, grandma's living at home with you and Johnny comes home from school with the flu, we'll give Tamiflu to grandma to help her prevent from getting it too. But yeah, it's the shortages are. I mean, it just seems to be the world now, doesn't it? I mean, it's not just medicines, but we run into shortages with everything. I don't think it's impacting much on a number of cases.
If you had a J&J vaccine and then a Pfizer vaccine, what would you recommend for a booster? And would it be okay to take the newest vaccine?
I would, if you had a J&J and then you had a Pfizer, I would go out and get the fall bivalent Omicron booster. I, by the way, call that vaccine the fall COVID booster because it's not so many words. I would go get it. The Pfizer makes one and Moderna makes one. You can get either. It looks like in the laboratory Moderna might be a little bit better than Pfizer's, but you know, if you go get the shot and they said, sorry, we only have Pfizer today, then you say, I'll take that one.
And we have another one here. If you have already had the flu before getting the vaccine, can you get the flu again? I've heard a person say that they already had the flu, so they had immunity against the flu. Is that true?
If you had the flu, generally, if you've had the flu in a season, you're not going to get it again because you get immunity to that flu. The one thing about influenza, though, just like COVID, it's a little bit shifty, and so it can change the expression of its outer coat. So that the immune system doesn't recognize it as well. So it'd be kind of like if you usually wear a blue coat and got a new red one for Christmas, and you start wearing that, people might not recognize you as much, right? It's the same sort of thing for flu. So there was the year right before COVID came, where we had kind of a bit of a bad flu year, particularly in late fall, and then the virus shifted, put on a different color coat, and then we did have some reinfections that happened in March of that season. So it can happen, but generally, if you've had flu in the season, you're not going to get it again.
You mentioned earlier about Paxlovid as being the only treatment so far right now for those with immunocompromised systems. How should people take that? Should they be more concerned, more vigilant?
So immunocompromised people, if they get COVID, yes, should be more vigilant and concerned, and they really should. If they test positive, you really should call your doctor. Most immunocompromised people are being followed by a doctor who specializes in that immunocompromising condition. So if you've had a kidney transplant, you have a kidney transplant doctor. If you have, you're on immunocompromising meds for rheumatoid arthritis, you have a rheumatologist, so on and so forth. So that's who I would call and let them know. And then they can get you the Paxlovid. There's one thing about Paxlovid that you have to work around, in that there are some drug-drug interactions, so that if you're on other medicines, you have to check those before you take the Paxlovid. And if there's an interaction between the two, then we either stop the other medicine for a few days or we change the dose of it to get around that. So you need kind of some expertise to help you with that. And most transplant centers or cancer centers actually have special pharmacy people who help do that. So that's part of the vigilance for that as well. There is one other medicine besides Paxlovid that could potentially be used. That's a pill called molnupiravir. I don't think that medicine works quite as well, and there are some concerns, particularly for women who are trying to get pregnant or who are pregnant. It's not a good idea to take that one. So almost all the time we use Paxlovid. And then if for some reason you still can't take Paxlovid and you get COVID and you're immunocompromised, we can bring you into an infusion center and give you an IV drug daily for 3 days called remdesivir. That's the drug we usually use in our hospitalized patients. But it has to be given by vein. So we have to do that in an infusion center. So that's sort of the third option. Paxlovid's the one we almost always use. And it's a short course of drug over a period of 5 days. And you take it at home, it's oral. Not many side effects. There's a little bit of a taste perturbation to it that people notice, but that goes away as soon as you stop it. So it's been useful. And the studies show it really helps keep people out of the hospital. It keeps people from dying. So. All right, we're talking about having another one of these on the 22nd of December. At this point right now, I think we probably will. Because it'll be right before the Christmas holiday. I think people might have questions. People might want to hear it again as we get through the holiday season. And we're certainly going to be able to provide a bit of an update on how bad the holidays might look, specifically for influenza and COVID.